Dear Chairman, dear colleagues, thank you very much for providing me the opportunity to discuss with you the growing role of multimodality imaging. So we already saw two beautiful presentations about the aortic valve disease involving the valve, involving the aorta. And my goal is to demonstrate that using echo, because I'm an echo guy, is very good, but perhaps we have to think about the other imaging modalities to best assess the valve, the sinuses, and the aorta. So the bicuspid aortic valve disease is not just a valvular disease. It's also what we can call a valvular aortopathy. And we know that it's a quite prevalent disease. We know that the prevalence of the ascending aorta enlargement is about 30%. And we know that the most prevalent complication is the need for an aortic valve replacement. And also, we know that some of these patients with an aortic valve, bicuspid aortic valve, will have an aortic dissection. The risk is increased by a factor of 8, according to the whole population. But this risk is not as high as we were expecting before. We know also that the prevalence of the ascending aorta aneurysm is relatively high, but we know also that the progression of this ascending aorta aneurysm is different from one kind of bicuspid aortic valve disease to another one. Some patients may have an ascending aorta aneurysm without any progression, and some may not have any aneurysm when you see the patient for the first time and will develop an ascending aorta aneurysm afterwards. So we have to be very careful to assess the valve, to assess the ascending aorta, but also to assess the left ventricle. We will discuss that later on. So we know that if we make the diagnosis of an aortic valve, a bicuspid aortic valve, it is very important because it will change the way we will follow the patient. And if we follow the patient adequately, the risk of the patient is probably a little bit higher than the risk in the general population, but it's not a very high risk of event. The risk of aortic dissection is not so high, and the risk of death is not so high also. It has been recently demonstrated, 3 days ago, I will say, in a paper from the Maris group providing us a meta-analysis about the bicuspid aortic valve, and the results are very consistent, demonstrating that there is an increase in risk if you have a bicuspid aortic valve, but this risk is very low, even if there is a risk. So we have to consider the fact that we make the diagnosis of bicuspid aortic valve. We have to characterize the phenotype of this aortic valve. We also have to look at the aorta and to characterize the phenotype of the ascending aorta dilatation. And we have to take into account, that has been already said, the age of the patient, the presence of a stenosis or an aortic valve regurgitation, because if we have this kind of risk factor, you will probably have an increase in risk of complication like aortic valve dissection. We also have to take into account the fact that if we have a patient with with hypertension, we have to treat this hypertension very carefully because it will also impact the risk of dilatation of the ascending aorta. So bicuspid aortic valve is a disease of the valve, but it is also a disease of the ascending aorta. We have to look very carefully at the valve, but we also have to look at the cardiac chambers. We have to look at the aorta, and we have some kind of specific topics that we have to deal with, like the Turner syndrome. We will discuss that later on. So if we just think about the aortic valve, we have several classifications. In France, at least, we use the Sievert classification, and the most prevalent phenotype of bicuspid aortic valve is a type 1 with a raphe between the left and the right cusp. So this is the most prevalent type phenotype of bicuspid aortic valve. But we have different kind of classification. This is another one. And the type 1 is still the one with the raphe between the left and the right cusp. But the type 2 here is without any raphe. And in the severity classification, the type without any raphe is the type 0. So we have to be very careful because according to the paper you will read, the classification is not always the same, and the meaning of what of the conclusion is not exactly the same also. So I'm an echo guy, so I think that we have to start with the echo. We have to look very carefully at the valve and at the aorta. If we have to assess the stenosis, if we have to assess the aortic valve regurgitation, echo is still the best tool to do this. We can use transthoracic echo, of course, but we have also to consider transesophageal echocardiography and 3D echocardiography to best assess the aortic valve and also the ascending aorta. But of course, if you can provide to the patient an access to the cardiac MRI, it's very important because it's a better way to assess the valve, but also to assess the sinuses and the ascending aorta, because you can orient the heart adequately to make sure that the measurements that you are doing are accurate, which is not always easy when you are doing echo. So we use in my institution the MRI, but we use also the cardiac CT because cardiac CT is easier it's easier to have the access is easier, I will say, and also it is a good way to see the valve, to look at the valve, and to look at the ascending aorta, and to discuss with the surgeon if you want to send the patient to the surgeon, because you see we have the valve, we have the coronary arteries, and we have the whole ascending aorta. It's very important to consider the fact that we start by echo, and we have also to provide to the patient another modality, because we have some strange history. We already saw some of them. I will just share with you these two patients. These two patients have a bicuspid aortic valve. These two patients have a raphe between the left and the right cusps. One of them has dilatation of the ascending, no dilatation of the ascending aorta, and the other one has an aneurysm, despite the fact that these two patients are 40 years old, without hypertension, without any difference, except the presence of the aneurysm of the ascending aorta. So it's very important to make the diagnosis of this aneurysm of the ascending aorta, and sometimes echo is not good enough to best measure this dilatation of the ascending aorta. So we have to do a CT or a cardiac MR to characterize the phenotype of the ascending aorta, and we have also several classifications for that. This is one of them. So we have the type 0, which is a normal ascending aorta. We have the type 1, which is a dilatation of the aortic root, the type 1 dilatation of the aortic root. We have the type 2, which is the dilatation of the tubular portion of the ascending aorta. And we have the type 3, which is a diffuse involvement of the ascending aorta and the transverse aortic arch. So it's very important when we see a patient for the first time to characterize the valve, but also to characterize the ascending aorta, because it might impact the prognosis, and it might impact the way you will follow the patient. But as we already saw, there are some papers in the literature, but some of them are providing very different results. So I will share with you some of these results to show you how complicated it is. So this is the first study that I want to share with you. This is a study demonstrating that this is a retrospective study, a monocentric retrospective study, and the authors were able to demonstrate that most of the patients with a bicuspid aortic valve have a raphe. Most of these patients have a raphe between the right and the left cusps, which makes sense to me. And they were able to demonstrate that there is no significant difference in the aortic dimension according to the bicuspid aortic valve phenotypes. So no difference if you have a raphe, no raphe, if you have a fusion between the left and the right, or if you have a fusion between the left and the non-coronary cusps. We have this great paper from the authors group using different classification. There is a classification for the valve and another classification for the ascending aorta. So you can use this classification, which is they are very easy to apply. And in this study, they were able to demonstrate that if you have a type 1, which means that you have a fusion between the left and the right cusps, you have an increase in risk of dilatation of the ascending aorta. And I would like to summarize some other studies. The first one from Shekoni in 2005 was able to demonstrate that there is no correlation between the phenotype of the aortic valve and the degree of dilatation of the ascending aorta. Another one was demonstrating that there is a faster progression of the aortic stenosis and the aortic regurgitation if you have a fusion between the right and the non-coronary cusp, or the left and the non-coronary cusp. We have a third study demonstrating that there is a risk of rapid dilatation of the ascending aorta if you have a fusion between the left and the right cusps, which is something that is not demonstrated in every studies. We have the authors group study providing us the fact that if you have a bicuspid valve with raphe between the non-coronary cusp and the right, or the non-coronary cusp and the left cusp, you have an increase in prevalence of the dilatation of the ascending aorta. But we have also this study from Birchner demonstrating the opposite. And the last study that I want to share with you is the Kong study, demonstrating that the aortic regurgitation is more frequent if you have a raphe between the non-coronary cusp and the right cusp, or the non-coronary cusp and the left cusp. The aortic stenosis is more frequent if you have a raphe between the left and the right cusp, and the aorta is more frequently normal if you have a raphe between the left and the right cusp, and the dilatation is more prevalent and more severe if you have a raphe between the non-coronary cusp on the left or the right cusp. So very conflicting results, demonstrating that it's very complicated to assess this patient. So probably we have to do the echo very carefully to describe the valve, to describe the ascending aorta very precisely, but we also probably have to send the patient for a cardiac MR or for a CT to have another modality to make sure that we are saying the same thing and to adapt the follow-up. So in the Kong study, they were able to demonstrate that there are some differences in the prevalence of the ascending aorta dilatation according to the phenotype of the bicuspid aortic valve, as I said before. And it has been demonstrated also by Koo in Jays in 2013 that if you have a raphe, as compared to if you don't have a raphe between the left and the right cusps, you have an increase in prevalence of dilatation of the annulus of the valve, of the sinus of Valsalva, and of the sinotubular junction. So it's very important to make the diagnosis of bicuspid aortic valve if we have a raphe, because the presence of the raphe makes the diagnosis more difficult. Then we really have to be very careful to use echo, transthoracic echo, but also to use 3D echo, CT on cardiac MR to make sure that the raphe is there, and this is really a bicuspid aortic valve and not a tricuspid aortic valve. So if you have a type 1, which means that you have a raphe between the left and the right cusp, you have an increase in prevalence of a dilatation of the ascending aorta as regard to the type 2 without any raphe. I want also to share with you this paper, which is, I think, very important, demonstrating that the severity of the valve disease impacts the aortopathy. So more severe is the stenosis, larger is the dilatation of the tubular aorta, and more severe is the aortic valve regurgitation, larger are the sinus. I think it's important to keep that in mind. And there is also this study demonstrating that perhaps the phenotype of the ascending aorta will impact the degree of dilatation afterwards. And it has been demonstrated in that very recent studies published 3 days ago that if you have a dilatation predominantly at the level of the sinuses with a normal or less dilated ascending tract, then you have a higher risk of progression of the dilatation of the ascending aorta. So the fact that the sinuses are dilated is a risk factor, and if you have a dilatation of the sinuses, you probably have to follow your patient more carefully than if you have a dilatation of the ascending aorta without the sinuses. And there is also this study that is not published yet, but demonstrating that if you follow your patient, the baseline aortic diameters does not proportionally predict the progression rate, which means that you see the patient, you make the diagnosis of bicuspid aortic valve, and you cannot be sure that if there is no aneurysm at the beginning, there will not be any aneurysm in the future. So you have to be very careful and to adapt the follow-up according to the fact that you make the diagnosis of bicuspid aortic valve. And there is also this study demonstrating that if you have a bicuspid aortic valve, you have a stenosis or an aortic regurgitation, you treat the stenosis or the aortic regurgitation, and it will impact the degree of dilatation afterwards of the ascending aorta. So the fact that you change the valve will impact the risk of further increase in dilatation of the ascending aorta. And in my institution, I will say, sometimes the surgeon don't change the ascending aorta when they operate the valve, because they think that even if the valve is enlarged, like something like 45 or even 50 millimeter, they don't change the valve if they think that the tissue is okay, because they know that if they change the valve, the risk of increasing of the ascending aorta will be decreased by the simple fact of changing the valve. But this is one point, but the other point is that we have to keep in mind that even if we change the valve, there's still a risk of dilatation of the ascending aorta, and we still have to follow the ascending aorta, and perhaps also to use CT or cardiac MR to best assess the ascending aorta of this patient that has been treated by a prosthetic valve. It's time for me to discuss very specific topics. First, we look at the valve, we look at the ascending aorta, but we also have to look at the heart, and we know that some patient might have a coarctation, some patient might have a natural septal defect, some of them also might have ventricular septal defect, but also mitral valve prolapse, and as I show you in this example, you can find a cleft of the mitral valve, or you can find a triatrial heart in a patient with a diagnosis of bicuspid aortic valve. So look at the valve, look at the ascending aorta, but also look at the heart very carefully, because sometimes you will find a ASD, a VSD, or maybe a triatrial heart, as I did 2 weeks ago. And there is also some strange things, like this paper demonstrating that if you are an African American, your ascending aorta dimension are smaller than if you are a Caucasian. But this paper does not provide any data about the prognosis, so even if you have a smaller if you have smaller aortic dimension, you might be at risk of aortic dissection. We don't know. And I want to finish with the Turner syndrome, because this is a very problematic subject, because the prevalence of the bicuspid aortic valve is very high, the prevalence of the aortic ascending dilatation is very high, and the risk of the aortic dissection is increased by the factor 100 if you have a Turner syndrome according to the age of the population. So it's a huge risk of dissection of the ascending aorta. So we have to be very careful, and the cutoff value that we use to define a dilatation of the ascending aorta is very strict, and we have to fear the fact that we see a woman with an ascending aorta with a diameter of this aorta greater than 25 millimeter per meter square, and we have to normalize the dimension because these women are small women. So we have to be very careful when we assess the ascending aorta of these girls, and we use echo, of course, but most of the time we send also these girls to the CMR to make sure that the dimension that we are measuring in echo are correct. And this is very important in this Turner syndrome population, to make sure that you have a bicuspid aortic valve, because the risk of dissection of the ascending aorta is increased if you have a bicuspid aortic valve as compared to the girl without any bicuspid aortic valve. And this is my last slide about the risk of endocarditis, and it has been demonstrated, and we already saw some data about that the risk of infective endocarditis in bicuspid aortic valve is existing, and it has been demonstrated by Christophe Tribouillois that the presence of a bicuspid aortic valve was an independent predictive marker of abscess formation. So if you have a bicuspid aortic valve, if you think about an endocarditis, be careful, because the risk of abscess formation is very high. So, dear Chairman, dear colleagues, my conclusion, so the valve is very important, not always very simple to make sure that this is a bicuspid aortic valve, especially when you have a raphe, when there are calcification. So sometimes it's very, very challenging using only echo. So to make sure that this is a bicuspid aortic valve, you may have to consider CT or CMR. And in the meantime, it's probably very important to check the ascending aorta, even if there is no dilatation at the first echo that you do, because it will help you for the follow-up. And there are specific situations like the Turner syndrome, which are very complicated to treat, to diagnose, because these are small girls, and you have to consider the normalization of the measurements to make sure that you don't miss a dilatation of the ascending aorta. Thank you.